to our Caribbean Climate and Health Workshop Series. This is the monthly workshop webinar that's focusing on climate change and non-communicable disease, as we've been working in the last few months and the next couple of months ahead of us. My name is James Hospitalis. I'm the founder and executive director of the Earth Medic and Earth Nurse Foundation for Planetary Health. Together with our great partner, the Global Consortium on Climate Change and Health Education at Columbia and the Healthy Caribbean Coalition, we're really happy to work together to put together this series. So here you see the partners in this initiative, and I'm happy that one of HCC's directors is with us tonight, Dr. Kenneth Connell. So we'll get a bit more insight into his views in that regard. Next. So the objectives for the series overall are to really, people who attend should be better able to explain how climate change affects physical and social environments, to alter the risks and vulnerability for NCDs, and in this case for heart disease and stroke. And heart disease and stroke make up the bulk of the non-communicable disease epidemic in many ways. Explain what preventive actions practitioners, patients, and communities can take. And this can include a variety of things, taking a climate health risk history, using communication materials, and in the work groups we'll be spending some time on that, and identify 3 priorities for action research on cardiovascular disease and climate change. So it'd be interesting to hear from our keynote speakers this evening what their thoughts are on priorities for action research on cardiovascular disease and climate change. Next. And so that brings me to a very pleasurable spot of introducing our 2 presenters for this evening, Professor Simon Anderson and Dr. Ken Connell, both of whom I've known for quite a while. And then you get the little bios that we officially have to go through with this process. But Simon is the chair and holds a chair in population and health science and cardiovascular medicine at this Georgia Lean Chronic Disease Research Center at UWI in Barbados, and where he's the director of that center. He read biochemistry in Mona and had a Cambridge Commonwealth Scholarship to read epidemiology in Cambridge. I subsequently followed my wife to Cambridge. He went to Cambridge, he really went. He subsequently studied human biology and genetics at University of Oxford. He held a prestigious National Institutes of Health Research Clinical Fellowship and an NIHR clinical lectureship during his postgrad training in academic cardiology. He has research interests in cardiovascular disease, genetics, etiology, and the emerging risk factors for chronic disease, as well as methodological approaches to large data sets to study variations. It's my great pleasure, therefore, to have with us this evening Professor Simon Anderson. Let me also introduce our other speaker, Dr. Kenneth Connell, who I work with, especially through the Healthy Caribbean Coalition connection. He's a consultant internist and hypertension specialist and full-time faculty at Cave Hill in UWI, Deputy Dean of Internalization and Recruitment in the Faculty of Medical Sciences, and chair of the Cave Hill Campus Health and Wellness Committee. A consulting physician at Queen Elizabeth Hospital, he manages both general internal medicine inpatient care and the resistant hypertension clinic. And I'm sure there are many ways in which, as climate is changing the environment and changing disease and risk occurrence, that's playing out in the hospital. He's the immediate past inaugural governor of the American College of Physicians for the Caribbean chapter, and he has received a number of distinguished awards for his excellence in public service, published numerous peer-reviewed journal papers on hypertension, and leads on the PAHO WHO Hearts program. Many professional recognitions. So Ken will be our second speaker, and both with 2 hats on, both an academic and Healthy Caribbean Coalition as a professional association and NGO in the civil society space. And what are his views on how that can function to address this challenge we have with climate and health, climate and NCDs, and climate and cardiovascular disease, as I'm sure you'll hear when these gentlemen speak. So thank you. Before the end of the session, we'll provide the link for continuing medical education credits. 30 minutes before the end of the session, you'll get the link in the CME chat, sorry, and that stays live for 2 hours after for those of you who want your CME credits, you'll need to click that link and fill it, please. Thank you. Do I deal with these now? These are the questions that maybe we should review this just before when we are about to go into the breakouts.
Sure, and the link for these questions will also be posted in the chat as well for easier reference.
Thanks, Carrie Ann.
Absolutely.
Thanks. There's actually a slight change in this program, and this is announcing next month. It'll be March the 23rd, and we'll be taking a slight change and looking at commercial determinants of both non-communicable disease and the climate crisis. Hearing from Nicole Foster next time around. Is that it for this deck, Carrie Ann? Okay.
Sorry.
So I think that. So welcome to those of you who've just joined us to today's session on climate change and non-communicable disease, focusing on cardiovascular disease. And our keynote speakers this evening, Professor Simon Anderson and Dr. Kenneth Connell. I'm now passing over for them to give their talks. Simon, over to you.
Thank you. Indeed, I'll just share my slides, which is ready to go. And, please tell me that I'm in the correct mode.
You certainly are, Professor.
Excellent. Thank you very much. Good evening, everyone. And I hope my background noise, I'm not at home. I can't control the environment as I do the presentation, and I can't lock myself too much in. I need to get some fresh air and to keep me awake through my own talk. So today we'll have a chat about climate change and cardiovascular disease. I'm happy to talk about cardiovascular disease because I spent almost half my life learning about that. Climate change is a new thing, so I'm not speaking to you as an expert in climate change, but based on what the literature has put out there, that's what I'll be talking about. There's nothing new coming from Simon A. on this topic. But I'd like to thank Dr. Hospitalis for inviting me for the chat, and I look forward to Kenneth's talk as well. So objectives, I'll just try to provide some context on a number of things because the time is limited to 20 minutes. Let's start the timer going. So I'll talk a little bit about what is cardiovascular disease and give a very brief review of the epidemiology of cardiovascular disease. I'll define climate change as I understand it and as it's defined in the literature, and describe how it's situated in the Sustainable Development Goals that are really important for all of us as we make our way forward to 2030. Try to contextualize climate and health using a framework approach, and then do some fleeting reviews of the data available. For example, data available from Lancet Countdown, a review of some of the evidence linking air pollution and cardiovascular disease, heat and cardiovascular disease, some projection data, and to summarize. There are multiple facets of climate change linked to CDD, and it's not possible to talk about them in 20 minutes. So I'll just focus on air pollution and heat, if that's okay for this presentation. I like to start with this slide when I'm talking about risk factors that I'm not used to, specifically the external environmental risk factors. And we've got this framework here that's been produced in the BMJ and the Thorax journal directly, that just links specific and general external environment together. You know, the climate, green spaces, urban environment, the traffic, the social environment, and social capital, with the specific external environmental factors like physical activity, your use of water, consumer products, tobacco, etc. All of those impact on health risks in the long run, but they also have a big role in the internal environment. And I like to look at this through the various omic technologies, but there are many ways of biomarker and prognostic markers that can be used to consider the association between any of these environmental factors during the life course dimension. So from birth through to, even before birth, from pregnancy in utero, all the way up to when an individual dies. So it is in that context that you have to consider what's going on here. So what is cardiovascular disease? For those who are not aware, it's really the disease of the vasculature. So with the heart and the heart vessels. And specifically, we tend to focus on the arterial vessels to some extent. And the arterial vessels take blood away from the heart to organs like the brain. So if there's a problem with the vasculature between the heart and the brain with a blockage or something like that, then you're going to have a brain attack, which is a stroke. There are vascular problems that can lead to peripheral vascular disease, kidney disease, and any other organ failure. Within the heart itself, there are multiple facets of heart disease, including arrhythmias and heart failure and coronary artery disease, which everybody knows about. So that's the context, and the epidemiology is very important because cardiovascular disease is a leading cause of death globally. Most people here who has any family who's died on that death certificate will be listed a cardiovascular complaint or diagnosis. An estimated 17.9 million people died from cardiovascular disease in 2019. That's 32% of all global deaths. And 85% of these were due to heart attack and stroke. Now, the problem for us living in low and middle income countries, or high income countries that are small island developing states, is that over 3/4 of the deaths are in our territories, in our geographic location. And of the 17 million premature deaths that are deaths under the age of 70 due to NCDs, 38% was caused by CVDs. And most can be prevented by addressing behavioral risk factors such as tobacco use, etc. But now we have new risk factors coming in. These are the emerging risk factors, and the climate change risk factors, which we'll talk about today, is what you'll see. And of course, these are preventable as well. So it's important that we detect cardiovascular disease as early as possible and to prevent it as early as possible. So my next slide is really about the situation in the Caribbean, because that's a global picture. NCDs is 78% of all deaths in 2010. It's pretty much the same amount when the last count was done. And 76 of all premature deaths are caused by NCDs. And again, CVD is the #1 cause, and followed by cancer, diabetes, and other conditions. So the point that I'm trying to make here is that there's an underlying problem already with cardiovascular risk factors. And the addition of a new or an emerging or preventable factor, such as pollutants, really make a bad situation worse. And the reason why that happens is because on the slide that you see here, we're looking at the proportion of individuals with hypertension. And in this data set, which is taken from across the globe, what you'll find is that for people with hypertension who have had their blood pressure measured, are diagnosed and are treated, those who are controlled, if you look at the slides for Sub-Saharan Africa and Caribbean, those are really low percentage of people who are controlled. So even though we can diagnose people, not a lot of people are taking control. And therefore, this is an important factor to try and avoid preventable risk factors like climate change factors. Now, if we look at the burden of stroke and risk factors in Latin America and the Caribbean, what I would like to show you is this scorecard, which lists individual risk factors ranked by the number of disability-adjusted life years, which is caused by stroke. And if you look on the far left panel, you'll see high systolic blood pressure, high BMI, smoking, fasting glucose, etc. But what you see after glucose are ambient particulate matter pollution and household air pollution from solid fluid. And if you look at the ranking across the globe, so globally and in Latin America and in other countries, high and upper income countries, the ambient particulate matter pollution is causing a significant number of disability adjusted life year. In other words, it's causing more disability than good. So what is climate change? Climate change is really about weather and climate, and weather is short-term changes in the atmospheric variables such as temperature and rainfall, which can change rapidly. So the weather is what's happening outside. I'm looking out at the Caribbean Sea. It looks great. Climate is a long-term state of the atmospheric variables like rainfall and temperature. So climate occurs over many seasons and longer. So if I came here 30 years ago and I was able to swim out or to walk out a half a mile, I think there's only a little quarter of a mile that I can do now. And that's the effect of climate change and global warming and all those things. So that's what we're talking about, climate change. So there are natural and human activity that influences climate change. So the natural variations like the Milankovitch cycles influence climate change to some extent. Those are periodic changes in the Earth's orbital parameters. Volcanic eruptions like the one, this is a picture of La Soufrière, they have an impact on climate change. But the most important factor that has an impact on climate change is human activity. So when we consider the Sustainable Development Goals, goal number 13 is really on climate action, but it's linked to other things like goal 7, which is affordable and clean energy. And it's also linked to goal 12, which is responsible consumption and production. And it's also linked to goal 11, which is related to sustainable cities and communities. And it's also linked to life below water. So climate action requires you to do all of the other goals and vice versa. So all of the 17 goals, you need to deal with each one, you'll impact on climate change. So how does climate change affect human health? So if you look at this framework here, the impact of climate change on human health and existing inequities, if you look at 4 areas: rising temperatures, extreme weather events, increasing carbon dioxide levels, and rising sea level. These are the things that are talked about mostly in the press. If you look within those domains, environmental degradation and extreme heat are critical factors that impact on health, and we'll talk about that. Air pollution and increasing allergens, we'll talk about that. But there's also issues related to vector ecology and living conditions and social inequities that impact on health. So I need to shift up because the time is running. So here I'm giving you another framework that looks at climate change and cardiovascular disease. And we are using the deep sea framework, which is driving force, pressure, state, and exposure, environment, and action framework, to contextualize the range of factors that should be considered when conducting an assessment on the health effects of climate change. The driving force issues related to population growth and technology, the pressure matters related to consumption and production, water release, state matters related to natural hazards and pollution levels, exposure to external dose, absorptions, and target organ dose. That's what you breathe in or drink in based on the water or the liquid or the air that's around you, and the effect on your well-being, mobility, and mortality. And there's always an action that can be done in terms of being corrective, being protective, and having some hazard management aspect to it. So this is sort of one way of contextualizing what's happening. And so what we have is a direct and indirect effect, the direct exposure and the indirect effect. So the direct exposure to extreme weather events, ambient temperature, heat waves, cold waves. When we say heat waves and cold spells, in the Caribbean, we don't get cold spells to that extent. We're always hot. So, but the data is coming from countries that have hot and cold weather. And so they're not really seeing what's happening in our context. And we need to be very aware of that. So we don't necessarily we get hotter in the summer, but we have a continuous heat wave in our setting. And the indirect effects are related to access to healthy food and clean water. You know, if you have drought, then you're not going to get the vegetables. You're going to have low vegetable consumption. That's going to link to poor health. Clean water, transportation, housing, electricity. All of these things are essential for the maintenance of cardiovascular health. And so if we look at everything in context, the the climate change matters, the effects, what we see is a lot of things coming together. So policy making influences in industrial emissions and carbon, that's PM, particulate matter, or CO2 and greenhouse gases. Those things directly influence extreme temperatures and altered meteorology and extreme weather events, which leads to things like the ozone level changes, wildfire issues, and damage to the healthcare infrastructure. And of course, the inhalation of particulate matter, for example, has a cardiovascular sequelae, including inflammation, electrolyte imbalances, thermoregulation, hypercoagulation, which eventually leads to cardiovascular deaths. So there needs to be a coordinated assessment, and what's been happening is that state actors or NGO actors like Lancet Condor have been collecting information over time and monitoring the development of key health risk indicators and how the trends have developed over the past decades and up to the current time. So they look at things like heat wave and food insecurity, vulnerable populations, this is aging or pregnant women or children, extreme weather events, floods, droughts, etc. And vectors, which include, which will cause diseases like dengue, etc. So here's an example of the impact of heat wave days on food insecurity over time, say from 2014 through to 2020. The key thing that you'll see across the next 4 slides is that the percentage change are always going up. So whether it's moderate food insecurity or severe food insecurity, there are increasing numbers or percentage change on the impact. So this is what happens to vulnerable population during heat waves. This is in infants, but there's you can look at over 65-year-old, you pretty much get the same trend from 1993 to 2020. The change present days having to do with heat wave is increasing. This is what happens with lethal extreme weather events like hurricanes, etc. And also transmission of vector borne conditions like dengue, the number of cases are going up. So let's quickly turn our attention to air pollution. And this is some data from 2013, which indicates that air pollution is the 4th highest ranking risk factor for death globally. 85% of the world's population live in areas where the WHO air quality guidelines are exceeded. And important thing about that is that air pollution was responsible for 5.5 million deaths in 2013. And I think that the numbers for 2019 is even higher. 10% of all deaths, as I indicated, were from air pollution. And this looks at the percentages or the proportions in relation to cardiovascular disease. Of that, there's a proportion that of deaths that are of cardiovascular disease are attributed to a stroke, or obstructive pulmonary disease, or respiratory infections, or lung cancer. So what's happening with air pollution and health? Well, if you look at my slide, my figure at the right, you will see PM 0.1, PM 2.5, and PM 10. Each of those represent particulate matter that have been measured at a particular size. So the PM 0.1 are particles that are less than 0.1 micrometers. And similarly, PM 2.5 and PM 10. Now,
Simon, you have 5 minutes.
Yes, that's fine. So we have a framework that links all of this together. And if you look at the PM 0.5, they go directly to the brain and to the organs, whereas PM 10 particles tend to stay in the respiratory system. And clearly what's happening, dependent on where you are in the world, the relative risk of cardiovascular disease increases as the PM concentrations increase. And similarly, in terms of mortality, you get the same direction, an increase in mortality as PM 10 concentrations increase. So this doesn't happen just in cardiovascular disease like heart attacks and stroke, which I've been talking about before, but in areas such as blood pressure. Within blood pressure, this is some data from the DASH children in London. There's a study called the DASH study. And what you're seeing, if you look at the bottom 2 slides, particulate matter 2.5 associated with an increase in blood pressure in the population of boys and girls. if we look at the long-term exposure to fine particulate matter and cardiovascular disease in China, there is some data that shows that CVD events and risk factors increase for each 10 microgram per meter cube increase in PM 2.5, there's a 1.25% increased risk of cardiovascular disease. So there are some suggested characteristics of air pollution to consider. You have the ambient, or you have the household, but you get an exposure response curve that describes the risk as a function of the concentration. And as I've shown you there, that has increased as you go with concentration. So in terms of heat and heat health action plans, I mean, high air temperatures and heat extremes are associated with a large burden of CVD. And under the influence of global warming and aging, the impact in those subgroups are significant. So for example, systematic review on air temperature, on mortality and morbidity in elderly. As you can guess, what it will show is that there is an increase in terms of short-term association between high temperatures and cardiovascular mortality. And one meta-analysis showed a 1 degree centimeter rise in temperature increases cardiovascular mortality by 4.15%. In contrast, the association between high temperature and morbidity were less conclusive. And so, for example, one meta-analysis showed that there's a 1.6% increase in MI related to 1 degree rise in temperature. And the data is shown in this slide here. So heat vulnerability impacts on age, your health status, pregnancy, isolation, personal behavior, medications, and socioeconomic status. And the contextual things are around it, the type of house, if you have air conditioning, if you have a green space areas, all those things impact on outcomes. So what can be projected from these things? Well, a number of projections show that heat and cold related deaths for a whole year will increase, and others estimate future temperature related mortality will also increase as well. So in terms of other situational factors, there's impact of heat on drug interactions, and Kenneth can tell you a little bit more about that, but heat has been shown to have potential interaction on some drugs. It can affect the absorption, distribution, elimination, and the therapeutic response, and in some situations can cause an effect that can be significant. Finally, and I got a minute to go, but pollution, climate change, and cardiovascular disease. The other factors that I didn't talk about was all those air pollution factors on the top left-hand side, the toxic materials and metals that go into the sea, the manufactured chemicals, and so on. And I think I have probably about 3 slides left. So if you don't mind, I'll get 40 minutes over. So this slide is basically showing age standardized deaths per 100,000 persons that was attributable to PM 2.5. And the deep red spots are where those are exceeded. B shows the number of deaths from pollution-related NCD globally. And as you can see, 5.1 million in 2019. And in D, the exposure response curve between PM 2.5 and cardiovascular disease models for a 50-year-old person. As you can see, that also increases. So in summary, with 4 seconds to go, we've reviewed the literature on the pathophysiology of cardiovascular disease and associated air pollution, heat, and other medical conditions. It's essential for cardiovascular specialists to work on with hospital administrators in healthcare system that they can practice and prepare for an increased impact of climate change on the number and types of patients that they see. Disruptions to the healthcare infrastructure due to events such as hurricanes is already affecting substantial amounts of delivery. And we have an opportunity at this point in time, before it gets too late, to adapt our practice to protect our patients in this changing climate and use our voices, as we do here, to influence the mitigation and adaptation strategies that are required to combat climate change. Thank you very much.
Thank you very much, Prof. Simon, thank you very much. You took the challenge to come and speak. You said you're not an expert on climate change, but you are a leader and expert in your field. You took up the challenge and came and addressed it and made many of the linkages, and there are many linkages, and you focused on air pollution in particular as a major cause of death. In terms of cardiovascular disease, you looked at the life course approach. So thank you very much. We're now going to hear from Ken Connell, who will bring his perspective, both from his academic viewpoint and his Healthy Caribbean Coalition NGO perspective. Ken?
What 1 second as I load Dr. Connell's presentation, we did get a question for Dr. Anderson in the
Okay.
chat. And the question was, how come there are more CVD factors or cases in low and middle income countries? Aren't there more traffic or industries in high income countries that cause it more air pollution?
So that's why I gave the background epidemiology first, because that gives you what you're starting with. We have to compare oranges with oranges. So if we start with what's on the basic epidemiology front, BMI, obesity related matters, diabetes, etc., we're already starting in front. And so by the time you add the very small percentages that that climate change factors can give, it doesn't really matter. You're way ahead to start off with. So that's the reason why we see more problems in our setting. And of course, we're not treating our patients optimally. I'll show this slide. We're only about 10 to 20% of people who know they have hypertension and have had a blood pressure measurement are at target. If people are not target for hypertension, they're not at target for diabetes. If they're not at target for diabetes, they're not at target for obesity. If they're not at target for obesity, they're not at target for physical activity. Therefore, when you add all those things together and they multiply, you get bad things happening. Thank you.
Thanks, Simon. Ken.
So thank you, James. And let me just thank Arithmetic for the invitation. I recognize I'm wearing more than one hat tonight, but I plan to make it fit or make them fit all on one head. Let me just start by being honest with the audience. So as an internist, as a practicing physician in a small island developing state such as Barbados, I was not convinced that climate change was my problem. And there's a reason for that. I had so many other health issues that I had the challenge of, the NCDs. Then, of course, came in the infectious disease problems. On top of that, the several various health systems issues. I kind of looked at climate change as someone else's problem. And so I was very eager to watch the news and support the climate activists and say, okay, this is a well done job because the earth and the planet is at risk and we need to do something to protect it for the future. But I was never able to see the link. And so when the organization I'm part of, the Healthy Caribbean Coalition, hosted the climate change conference here in Barbados a few years ago before COVID, which is what BC is now referred to as, I thought, well, this is bizarre. Why are we having a conference on climate change and NCDs? Haven't we got lower hanging fruit? I'm going to put it to you practitioners. I know many of you are practitioners out there. This is our low hanging fruit. In fact, this is the thing that we should be focusing on as much as the traditional risk factors. And so I'm going to move on to my second slide. So over the next 15 minutes, I hope that you would appreciate that there is an interrelationship between climate and cardiovascular disease and cardiovascular health, as Simon just went through brilliantly. Also recognize the particular vulnerability of small island developing states. Everyone is at risk as long as you're on this planet, but perhaps some are more at risk, not only because of their geographical position, but also because of their geopolitical and economic position as well. Hopefully, I will provoke you to identify some barriers and hopefully come up with your own solutions for the development of a more resilient health system or health systems within the Caribbean space. It only takes a pandemic for us to kind of sit back and recognize maybe even the most resilient health systems in our world are not as resilient as we thought they were. And certainly climate change has the potential of doing so as well. And then discuss some local challenges. I promise that the examples I've cited will be relevant for the Caribbean and opportunities in your breakout rooms. Next slide. All right, so here are some photographs, and this is really what clenched my whole or piqued my interest in climate change. The photograph here to the bottom left of the screen is a coastal area in Barbados, right? It's on the South Coast, and I grew up on the South Coast. And I spent a lot of holidays in this beach area. And of course, a lot of holidays then were spent overseas. So this is kind of like my first staycation. And it happened that I couldn't travel anyway, so it was great. I was there. And then it struck me how much the coastal environment had changed. Here is this place that I've lived all my life, slowly changing over time with erosion. I said to one of the hotel workers whose dad actually worked at the same hotel, so it's intergenerational, that, you know, all this place, all this area here was part of your hotel landscape, and it's now being completely eroded by the beach. And of course, there's a whole lot of sand there, but the water would come right in. And I remember growing up in that area, and it was completely different. Now, here is the top left of this collage. And look at this. This is, can you guess where this is, anyone, or what event caused this? I'm going to look in the chat quickly. All right, so this
volcanic eruption in Soufrière, St. Vincent.
There you go. But which country do you think this is in, Damien?
Barbados.
It is. Can you believe it? So a natural disaster in St. Vincent. This is the parking lot of the hospital where I happened to be on call that day and could not get in in an emergency to be with the university team because I couldn't travel on the road. And this was something why the Soufrière volcano eruption and the ash fall was so critical. There really wasn't as much prior warning as you would get for a hurricane. So everyone was kind of at home. If you're in my generation, you kind of think, what is this ash fall? Anyway, I guess you're going to have some dust outside, maybe stock up on some inhalers if you're asthmatic. And boy, was I wrong. I mean, my parents' generation certainly knew that there was a lot more, but I didn't. And then, of course, you have the landslides in Haiti. And this is just Nassau before and after a major hurricane. These things really devastate a country. And so you need kind of activism at the highest level. Next slide. And certainly we have seen some activism at the highest level. Prime Minister Motley has been on the global call to action, championing the climate change on behalf of the region, but really on behalf of a world that seemed to have become so accustomed to the sound bites of 1.5 and 2 degrees. You know, after a while you think, oh yes, this is another 1.52 degrees chorus, and therefore the call to action is weakened. Somewhat like the call to NCDs or NCD action. And I hope to convince you that part of the problem with both climate change or the barrier of climate change and NCDs is the fact that the gap is so wide. In the UK, there's this sign called Mind the Gap. The gap is so wide, you can't see the relationship between the two, the outcomes, the heart attacks, the strokes, the excess mortality, and the climate change, that you ignore it. The gap is extremely tight or non-existent when you have a virus that's affecting someone who's becoming ill the next day or within a few hours, and you can see the contagious nature of a virus, but that's difficult with climate change. Next slide. So Simon has beautifully summarized this, and I think you quoted 5.8 million deaths from air pollution, and you did suggest it was slightly higher. It's about 7 million deaths now attributed to air pollution for stroke, heart disease, lung cancer, COPD, and all those other diseases that we see every year. And the Caribbean is really not spared. We are part of it. I mean, we may not create the issue of air pollution, but we certainly feel the impact of it. Next slide. And this triangle is something I like to show to practitioners because, as I said, it's so easy to kind of separate climate from health. So if the mitigating emissions, you reduce air pollution, you also reduce climate change, and you really protect health by directly on the impact that climate change has on our physiology. Simon hinted also at the impact it has, particularly in my area, on drug pharmacokinetics and the way drugs behave within an organism. But then there are the indirect impacts that I want us to concentrate on, because quite often we think about, as healthcare workers, the physiology. But what about the impacts to things like access to healthcare? In a landslide, traditional access is lost. In an ash fall, traditional access is lost. What do you do? Because illness does not pause. So you need some way of kind of continuing healthcare despite what is happening. Next slide. And there are some solutions which are mentioned. So the same things that impact on physical health, change in transport, so that we all moving a bit more and less air pollution from the motor vehicles, green spaces, and employing a lot more physical activity, reducing air pollution. These things have impacts on also securing healthy foods. They have direct impacts on both NCDs as well as climate change. So we're all part of the same choir. It's not just the climate change people and the NCD people. We're all singing the same chorus, hopefully. Next slide. And this slide just shows the new WHO air quality guidelines. They set clear goals to help improve air quality for all. How many of you, just by a show of hand, had any idea about the WHO air quality guidelines? I'm looking in the chat. And I see Kirk's hand up, but Kirk, I would expect you to know about them. Exactly. And so to a group of internal medicine residents who are going to be the next leaders fighting the health system barriers and issues, they had no idea that there were even these targets, let alone what they were. Now, this is a crisis for us. And I'm going to move faster now. How do you bridge the gap on NCDs? Because I suggested that it's the gap that's causing the problem. You can't see the risk from the outcome. One way is through education, which is what we're doing now. And the other way is through innovation, using NGOs such as Healthy Caribbean Coalition to get stakeholders at the table to appreciate that there is a link and we need to work together to solve it. And so HCC, next slide, published this, next slide, published this guideline or statistics for the region, 7 out of 10. So it gives you basic statistics and how many countries are affected by air pollution and what are the major sources of air pollution, what are the various interventions to counteract, those kind of things. It's very palatable. I would encourage you to read it. The one document I want to encourage all of us to sit down and really digest, healthily digest, is this document by the NCD Alliance, which is called the NCDs on Climate Change, Shared Opportunities for Action. If you can just download that, it goes through in a very kind of palatable way to healthcare providers. What are some of the ways that we can react to address the climate change burden? Next slide. And Simon's done a good job at this, comparing cold and hot climates and the impacts on the physiology. You would not believe, although we don't have cold waves, we probably have a continuous heat wave if you ask many people in the north. We have noticed weather pattern changes in Barbados. We have seen a lot cooler nights. And I suspect that it might not be the absolute temperatures, but it might actually be the change in temperature that might trigger some physiologic mechanisms that we mentioned as well, including hemostasis and clotting mechanisms as well. So these are things that we need to study in our own environment where there aren't significant shifts in temperature. And so I want to go on.
5 minutes.
So in my last 5 minutes, perfectly on cue, James, I'm going to go on to the situation one that you're going to go on to in your breakout rooms. Next slide. So here's what I call pandemic medicine. Of course, you had the cessation of health services during the COVID-19 pandemic, and there were limited access to the most vulnerable groups, including those living with cardiovascular diseases. Health systems were overloaded with the surge in cases. Practitioners were shifted to isolation centers and had to be involved in vaccination programs, swabbing, and everything to do with COVID. And we kind of forgot that other things were occurring. And there's limited infrastructure for telehealth, including telemedicine. Next slide. And so my questions to you, which have been beautifully summarized by Paula is, what are the major ways in which the pandemic has affected care delivery in terms of patients, healthcare workers, and the health system in your country? And what are the key communication challenges experienced during the pandemic? And how are they, or how were they addressed, including miscommunication? Like climate change doesn't really exist. And I think that one world leader was quoted as saying that. And what was the key role played by political leadership in responding to the pandemic and also climate change in your country? Next slide. So natural disaster number 2 is, of course, the ashfall. So unexpected natural events pose an additional burden. SVG La Soufriere, volcanic eruption resulted in almost 1 week of ashfall. In several territories, it was longer. I'm still cleaning up ashfall outside occasionally. So volcanic particulate matter and the respiratory diseases that come along with it. And we're still in the middle of a pandemic. So next slide. So using any natural disaster in your region, I'm sure you don't have to look that far. Earthquake, landslide, hurricanes. Who are the most vulnerable groups, again, for these events? And how can the health system potentially plan to prioritize cardiovascular disease care for these groups? And what non-healthcare healthcare services may need to be employed to assist in care delivery? Think about things like the army and non-traditional forms of transportation, those kind of people. How are you going to bring them into the healthcare delivery team in an emergency? Next slide. So final situation is in a rural clinic. Several villages have lost access to rural clinic in St. Joseph. The clinic has since been closed due to underuse. There are paper records of patients still on site, but no one can access them. And there is no central database of health data for any of these patients. It's just kind of been scattered to other community clinics. Next slide. So what are the unique challenges in managing patients remotely? And we will go into these questions in the breakout rooms. Summary slide. Next. You can go through these quickly. Global climate change phenomena have significant impact on SIDS. International organizations have called attention to this with calls to action, but really we need to now on the ground needs to be work to action. Regional examples of the effects of climate change can lead to sudden disruption in health services, but we really do need novel ways to build more resilient health systems. And this is where NGOs like the Healthy Caribbean Coalition come in. There may actually be lessons to be learned from COVID-19. And I will close my presentation here, but I really look forward, next slide, to discussing some of the solutions in the breakout groups. Thank you. James, over to you.
Thank you very much, Ken. Thank you, and thank you for sticking the time. Wow, you covered a lot of important stuff. Starting off by again, sticking the truth, saying that you were a bit of a denier, or what is this big climate thing about? And you've come to realize, as most people, when they start to explore it, that this is a humongous threat to public health. And on the other hand, climate action, especially mitigation, is very good for health, particularly NCDs, when you look at transport and air quality and the food we eat, and how changes there can both benefit cardiovascular and climate change at the same time. So that alliance between health and climate interests, I think, can only be to mutual benefit. I do think that COVID has had a number of positive lessons that we see from the way data has been collected and shared, innovative use of Google Sheets and other types of technology, telemedicine approaches, which is among the questions we'll be looking at this evening. So thanks again for that. Thanks to both of you for setting the stage for this evening's session on climate and cardiovascular disease and the many connections that there are.
Doc, we have a question as we're preparing for our last presentation from our work group. Nate says, during disasters like volcanic eruptions or other disasters that impact cardiovascular systems, do we see a sudden surge in patients seeking care, or is the increase protracted over several days or weeks? Dr. Connell, Dr. Anderson? I think either one might
So-
be.
Sure. So I think certainly something like volcanic eruption, there's going to be a sudden surge in respiratory presentations. And, so the Asthma Bay, which in our hospital, which was already kind of, well, let's just say reformatted or reconfigured because of COVID, became saturated with people with acute asthmatic episodes. But interestingly, cardiovascular events also increased, whether it's the additional stress, what happened during in the eruption. We saw a peak in, certainly a rise in cardiovascular events, both heart attacks, but also strokes at the hospital. Now, the interesting phenomenon that has occurred in COVID, which you could say is a result of climate change as well, we saw a very protracted kind of long heart failures kind of increase of numbers, which caused a big problem for our hospital because most of our staff were involved dealing with the pandemic. And these are people who did not access health systems for a few months because they didn't want to get sick. And they were at home rationing medication, all those sorts of things. So we did, so it is acute and it is also protracted as well. We don't know how protracted this will be as we expect the long-term effects to evolve over a long period of time.
Thank you,
Thank
Dr.
you.
Dr.
Thank you, Ken.
A hand from someone named Christopher.
Yes, and there was also a question earlier from Rose Schneider. What percentage of cardiologists in the Caribbean are aware of the effects of climate change on their patients? Ken, Simon, what do you think? You said there's one other question.
That's a research gap question.
It is.
That's a
It
quick
is,
default
certainly.
answer.
I could tell you
Nice.
certainly, if you want to ask what percentage of residents in training in internal medicine are aware of the effects, that's almost zero. I mean, they are aware that climate change is out there and somehow there's a link, but if you had to ask them for concrete relationships between the two, they would definitely struggle. And they're the next leaders driving this whole fight, really. So it is scary. And obviously they're the future cardiologists as well.
Thanks for that frank, brutal honesty with what we face. And I hope you'll work with us then as we campaign to make doctors and nurses and others aware and get them woke to take action to improve their health and to improve their country's health. So I think we're switching gears now to hear from some of our working groups that have been working on materials for climate and cardiovascular disease. Kesselin Lizama, Dr. Simone Charles. Simone is over in Michigan. Kesselin's in Belize, and Vashti, I think you're in New York, right? Who's giving this presentation? Is it yourself, Kesselin?
Yes.
Yes. Excellent. Okay, good.
Okay, so we've heard quite a lot of information that we've had so far, and it's good information that we need to hear and information that needs to be shared with our wider communities. So we talked about having, we spoke a bit about the vulnerable populations and living in small island states. And so knowing all of that data that's out there, knowing that there are areas in which there are gaps for the Caribbean, our work as work groups attached to this webinar series is to pull out some of that information and to come up with different ways that we could present this to the general public, and also in ways that we can kind of push more for healthcare providers to be more aware of climate change and its effects and its relationship with NCDs. What we have here is our work that we've done with our work group. We came up with different tools. It's a group of us working. We're using the data that's available through government documents or through documents that have been published. And we're using this and putting it together in some unique ways. We've tried videos, we've tried posters, we've tried brochures. So here's an example of one of those tools that we've created, and it's something very easily shared. You could share it to your Instagram, to your Facebook, you could send it to your friends or in your various WhatsApp groups. And what it does is just pull some of that information to share it with others. So here we're talking about climate change has direct and indirect effects. And we talk about some of those direct effects, extreme cold, heat, air pollution. We talk about the indirect effects that it might have, where extreme flood waters or more frequent hurricanes can cause limited access to healthy foods. It can make areas that were not once flood prone, now prone, and that affects our access to health services, it affects our access to healthy food systems. And then it also brings to light that in some of our indigenous communities in our various countries where their lifestyles may be a little bit different, where they don't have more up-to-date technologies, right? Because they choose to do that for whatever reason they have. And we know that these are the communities that are most prone because they don't have that easy access. And so these are the ones that tend to take a longer time to catch up. And that also puts to light all of our other vulnerable populations, such as the homeless, the elderly, the young, and pregnant women as well. So when we talk about sharing some of those information and trying to pull it out, we want to give very brief information for them to grasp very easily. So we talk about how to improve cardiovascular health under the effects of climate change. And we've chosen to focus on 4 here for this presentation. So we look at reducing the overall risk for heart disease and stroke, limiting exposure to air pollution, extreme heat or cold, paying attention to air quality indexes, and take climate change action in our homes and communities. And we focus a further going in depth with these areas as well. When we look at reducing the overall risk of heart disease and stroke, we can consider healthy behaviors. So making sure that you have regular doctor visits, that you're going for your checkups to time, monitoring your water intake to help prevent you from being, falling victim to severe dehydrations, especially in our elderly populations, those living in homes. We want to ensure that we're looking after their best interests. Also eating well and balanced meals. And we know that there are some caveats with this because it also is so closely tied with our socioeconomic status in terms of affording food. So these are things that it's there and we have to look at very closely as well. One of the biggest things that we've discussed, and we touched it a bit in the previous presentations, is knowing your underlying conditions. Are you hypertensive? Are you diabetic? Do you have a predisposition to cancers? These are things that are also important for you to know so that you can continue on that path of being knowledgeable of the things that are exposures and where you stand with climate change and the effects that it has. Also, one of the biggest ones is reduction in our stress levels. And for all of us, we know that might be a little bit difficult, but it's great to learn different strategies so that you can prepare yourself for a better quality of life. When we look at considering the risk, reducing the risks and exposures, there's also reducing or quitting smoking, assessing our home environments in light of all the information that's out there. How can we make few economical changes to have a better, to create a better environment for us to live in? We also want to look at this inside of our workplaces. So we're thinking about those occupational hazards that we are exposed to. Specifically here, when we talk about our agriculture workers, right? Those persons who are exposed to the sunlight all day, we know that they are more at risk for developing skin cancers because of their exposure as well. So we want to also bring up awareness to the public for them to look at these in terms of considering our activity levels, exercising more. So we're focusing on a lot of those individual actions that persons can take to help to reduce their risk for cardiovascular diseases, and thus the overall effect that they'll have from climate change will be much different. When we look at paying attention to the
2 minutes.
Yes, when we look at paying attention to weather indexes, it's utilizing the different apps that are out there. So there's many different weather apps that are available. You can watch your air quality indexes, and these could give you a good hint as to what the outside temperature will be, what the overall air cloud coverage might be, and you can prepare yourselves before leaving home. And also taking climate action in our homes and communities. So using the 3 R's, utilizing fuel efficiencies in different ways that we can, whether it be an electric car or taking public transportation instead of driving to work. And of course, advocating for policy, national level policies that help to reduce emissions. When we look at healthcare providers, there are 2 basic things that they can do. And one of those is just conducting really great in-depth patient survey at the point of contact. And so we're paying close attention to our patients' environmental exposure history, making sure that we're looking at the type of occupation they have, the exposures that they've had, where they live, other stressors, and advising them properly on how to take care of themselves. And also we want to look at their medical history. So we know those that have had previous cardiovascular issues, heart failure, whether they had a stroke or a ischemic attack before, this increases their risk of having far more complications with climate change and with exposure to other pollutants and for their overall health. So these are just some tools that we have. These are posted on the website for you to review. And as we head into the breakout sessions, we welcome feedback to the tools that were presented, and of course, other ways in which we can present all of this information for the general public. Thank you.
Thank you, Kesselyn, for walking us through some of those materials for patients in community where climate and cardiovascular disease are concerned. Thank you. A lot of good practical tips that could be used in different settings and in different times. So are we going into working groups now?
I am prepping that to go into the little think tanks, and just a word of advice, I'll be posting your conversation prompts in the chat in just a moment as well. And
Thanks, Kerry-Ann.
I also wanted to ask if folks have any questions for Kesselyn. I know we have to go through material pretty quickly, but please drop your questions in the chat or unmute yourself as we make this transition. Your time this evening. Dr. Hospitalis usually wraps us out. Yes, today can be hard. Yes, today was a hard day. Today was just in that last moment, you know, you're crossing the finish line and you trip. Yeah, boy, that was that moment. But
Well,
thank you all.
Thanks, Kerry-Ann. In the few minutes we have left, any takeaways from the different groups, people can pop it into the chat. We'll also be having a follow-up email to this. To yourselves, Ken and Simon, I'm going to give a special last word, as it were, having participated, including in your groups. What did you come across? What struck you?
Before you say that, don't forget to fill out the CME forms for people who want CMEs. Post it again in the chat. Thanks.
Thanks, Paula.
Do that now. Thank you.
Yeah, so one thing I thought was a practical take-home message is that healthcare providers need to be a lot more alert about the extreme temperatures we're now experiencing in the summer months, and to maybe give practical advice to our patients and colleagues and friends on ways that they can reduce the effects of heat waves and extreme or heat-related illnesses, because we do see them. People collapse all the time. The last 2 summers in Barbados, literally, our ERs have been kind of seeing surges in elderly people who were, as I said in the group, left at home by their relatives. They're not really drinking as much water as they should. Come back home 8-9 hours later after work, and they're on the floor unconscious. So things like adjusting diuretics, those kind of things are practical things I think we can do to counteract the much hotter summer months that we're seeing now.
Simon, are you still with us?
Yes, I'm still with you. From my perspective, I think the key thing is, as you mentioned, just as we were talking about technological failures, it's very important that we put in place backup infrastructure and plans to deal with climate change that is of a sudden and mitigating nature, like volcanoes or floods, etc., and hurricanes. Because that's really one of the critical ways that people tend to lose their way in terms of managing their condition and lose their life because they're poorly managed. So we must have our backup systems, must have a resilient, all of community thinking system. So it's not just myself and Kenneth as clinicians must think about what we want, but society should say, well, this is what you also need. And contribute to that conversation. Thanks.
Thanks, Simon. I think one thing that jumped in our group was talking about vulnerability and people accessing and understanding messages and trying to communicate that you have differently abled people speak different languages. You have elderly people who may not be savvy with the technology. Some people just don't have access. They're not on any kind of technology. So even as we embrace the social media, we also have to look at the traditional channels and faith leaders, community leaders, others to reach people. Any other anything in the chat that folks have put?
No, they were just demanding the CME link.
Well, actually, one of the things that stood out for me was the whole question of the vulnerable groups in terms of the aging population and things like that. And as we think about this whole policies on health and climate change, we have to think about how do we get on the front line in terms of getting the information about the vulnerable groups, supporting those vulnerable groups, and also getting the right information to help with those vulnerable groups, addressing their vulnerabilities in terms of the climate impacts, in terms of like heat, especially, which we also see that we are in a period where we're getting like extreme heat. For some, right now in Jamaica, for instance, there's a drought warning. So you're trying to control water usage and all of these type of things. And sometimes the elderly and groups like that may be home alone, and there will be really no community monitoring. So I do think that one of the things that we'll see more of with this whole question of climate change impacts on health is also a need for more community care and support and those monitoring and surveillance in the community. And this also really will call for greater partnerships and collaborations with NGOs and other partners to really help with our monitoring, because I don't think anybody can really afford to have like, you know, very expensive regimes for monitoring and surveillance in the communities. I think it's just some of the things that we also have to think about.
That.
Yeah, I think this last point by Claudia was mentioned in the group I was at as well. I'm not sure if Claudia that I visited, that considering government policies protect vulnerable workers with water breaks and mandatory water breaks so that they're not out there in the hot midday sun, which most of us can kind of avoid, but they can't. So there needs to be strong public policy to protect these workers, because it really is an occupational risk, even times in shifting work times and slots. But again, mandating breaks. And back to schools, perhaps schools should have mandatory water breaks. You shouldn't be sitting in the classroom for half an hour without being allowed, or any time for that matter, to have a water break. You should have free access. So children should have free access to water during lessons.
Schools have a set of issues in this space. Many still have a tin roof, and as it gets hotter, it's difficult for the kids to learn. Some are lining up in assembly in the hot sun for 45 minutes. And it's too hot, so you need to maybe plant trees and have other solutions. Carrie, you're coming. We probably should be winding up. Christopher Chinapu put up his hand.
Yes.
One last intervention, because I think it's actually connected to what Kenneth actually just mentioned, but it's also so important that definitely we need to have those type of policies across the board. But we also need some spatial monitoring, and we need to also think about the citizen science in all of this, because I do believe too that if we can have citizens monitor their heat, monitor their temperature, and then we also combine it with like GIS and spatial monitoring of the spaces and check the coverage and the heat, where the heat is at, I do think that we could actually get on the front end in terms of, you know, a sort of healthcare in advance, you know, more with some intentionality as it relates to the policies that evolve, and also with the monitoring and surveillance mechanisms that evolve from a kind of management perspective.
Thanks, Chris.
Yes. Oh, Keslin has another. Shall Keslin close us out, Dr. H?
Yeah, go ahead. Close us out.
I think I just wanted to add here that education is one of those key points to our preparedness, and understanding that climate change is real and that it does impact health on a whole can help to improve our quality of life. So exactly what we are doing here, conversing about it, talking about it, that is what we need more of. So, you know, as we are all professionals in varying fields, I, you know, encourage you all to continue that conversation, share it as widely as you possibly can, and maybe even to those that you think that they absolutely wouldn't believe. Bring on the non-believers, because I'm sure that, you know, a lot of us were non-believers at one point, seeing it very difficult to see these connections. So the more we have this conversation, the more aware everyone can be, and it helps us to change a lot of those things that we were doing, you know, just by tradition and affecting our own health. So continue the conversation.
Thank you for that advocacy, Kesselin. I don't think I could close us off on any stronger a note. Thank you all for attending this evening, our webinar workshop, Climate and Health. Thank you to our keynote speakers. Thank you for our team, that both on the arithmetic side and the GCCHE side, Haley, and to HCC. Great to see you, Ken and Simon. Special thanks. Thank you all. Have a good evening. See
Thank
you
you.
next month.
Have a good evening.
Good
Thank you.
evening.
Take
Stay
care.
well.
Bye.
Bye.
Bye-bye.
Good evening.